It's good to still see you all, dear DevDays participants. I mean, outside it's 28 degrees and there's boats in the canals and everything, yet you chose to stay here. I thought the only disadvantage of having this thing in summer is that everyone would be like, oh, no. But look at this, still a big group, and I'm truly happy for that. Next slide, I think. Yep. I just have a few short things to say, and then I leave the stage to the really important persons here, which first off is Dawn, and afterwards we'll have Grahame to say the final word, which is I don't know, like 12-year tradition by now. And what's also a 12-year tradition is that we then have that final drinks together, after which it will get really lonely here. And I'll have to, you know, get used to the fact that it's not so busy around me anymore. So, yeah, I'm gonna miss you all, but, well, there's always a next year and so on, right? Okay, but first, trees for all. It gets harder and harder because we don't have cash anymore. And anyway, we have 53 trees bought while registering, and we managed to get another 42 in, so that's 95 trees. And as I promised yesterday, Firely will double those, so that will be 190, correct? Right, 190 trees to compensate for our travels. Each will double that. Well, thank you, Mario. Woo! Yeah, Simone's dog agrees. Yeah. Isn't he the sweetest conference dog ever? Like he walked in everywhere yesterday evening. Oh, I love that dog. What's also, I mean, I can imagine that you're on the way back and you're like, oh, I already missed my dear friends. Well, we have got good news for you. As soon as we can, we'll be sending you an email with a link to a photo album filled with beautiful reminders of the past few days. You've seen our photographer walking around. There were also cameramen, so there's more coming. But the first thing we'll have is a link to the photo book of the past few days, so you can already start enjoying that a little bit. Having said that, let's get to the real content. And I'm not going to introduce you. I'm just going to say, here's Dawn, and let's go.
Okay. I've got a mic.
Oh yeah, you get a mic.
But I need this slidery thing. The clicker. It'll be really boring if I have to stand and talk without slides. So thank you very much for inviting me to this conference this afternoon. My name's Dawn Dowding. My official title is Professor in Clinical Decision Making. I work at the University of Manchester in the UK. And I'll just start by saying that thank you to Reen and the organisers for inviting me to this conference. I said yes and then thought, oh my goodness, what have I done? I don't know anything about HL7. I know nothing really about fire. I'm not a developer. I sit on the other end of the design and development phase, if you want, looking at implementation. But they reassured me and said, no, it's fine. You're exactly what we need. So I'm hoping that at the end of this, you'll still be happy you've invited me. Maybe not. And I also just want to say thank you to all the very lovely people who have spoken to me during this conference. It's the first time for around 20 years I've been to a conference and I know nobody. I literally knew nobody when I arrived on Wednesday evening, and you all have been wonderful. So I just wanted to say thank you for that as well. You're a very lovely community, and I will be back just because you're just so nice. Thank you. Okay, my job here is done. I don't need to do anything else now. So, the title of my topic is Where's the Nurse? And what I wanted to do was just tell you a little bit first about who I am and why I'm standing here. So in 1986, I went off as a bright-eyed 18-year-old to St Bartholomew's Hospital in London to do my nurse training. And yes, that is me, and no, I haven't aged at all. Okay? And alongside my nurse training, at the time in the UK, nurses didn't do degrees really. I did a sort of sandwich course. So I did a degree in psychology at City University in London. So the other two photos, the one in the middle is the fountain at St Bartholomew's. It's the oldest hospital in the UK. It was founded in 1618 by a monk called Ray here. And there was a legend that he used to walk around the hospital, but you could only see him from the knees up because the ground has risen since then. And the other photo is City University, so I did a degree in psychology. Nursed in intensive care for a few years, but then realised that actually research was my passion. So I went back, I got a job as a researcher at Surrey University, and while I was doing that, I did my PhD part-time. And the focus of my PhD work was looking at how nurses communicated information when they changed their shifts. Now, at the time, it was the early 90s, we didn't really have computers, it was completely paper-based. And I did some work looking at the effectiveness of that communication. And what came out the other side of my 3 years, I went in going, it's really important, it's a really effective way of communicating things. I came out 3 years later going, well, that's a terrible way of telling people about information to do with your patients. By the time it's gone through 2 people and been written down on various scraps of paper, what's left is probably not very accurate, certainly not efficient, and it's definitely and has an impact on patient safety. So that really, I guess, was the beginnings of my work looking at information transfer, communication, and decision-making. So moving on, I've had a very long career looking at, firstly, nurse decision-making, and then clinical decision support systems, clinical decision support tools, and how can we develop informatic solutions, computer-based digital technologies for nurses to use, which help them make better decisions in practice. And that's involved a variety of different studies along the way. A lot of my work has been looking at how nurses use systems that have already been implemented and how that impacts on their decision-making. But I've also been involved in some development of different technology tools, mainly visualized ways of giving information to people based on dashboards. So I've got this sort of cohort of work which goes all the way from some insights into designing, co-designing technology solutions, all the way through to how is they used in practice. So I guess that's why I'm here, to talk to you about my experiences and what I've learned over the years from doing this research. The first one is, and this is not going to surprise you, nurses are really important, okay? They make up 59% of the global healthcare workforce. In the UK, we have 700,000 registered nurses on our professional register, compared to 360,000 doctors. And the bottom graph here with the yellow and the brown, the yellow is the number of nurses per 1,000 population in a number of OECD countries. And as you can see, for the majority of countries, the proportion of nurses is way higher than the proportion of doctors and other healthcare professionals. Okay, so that's my first bit of learning. Sorry, I'm going to look at my paper now just to make sure I haven't forgotten anything else I wanted to say here. Okay. My second bit of learning is that nursing's work is actually pretty complicated. And if you're not a nurse, you probably don't realise just what goes on under the covers of what nurses are doing. And there's a lot of research in my world about the hidden labour of nursing, the hidden work that nurses do that keep everything ticking over. We are with people in hospital 24/7. We care for patients 24/7. We're quite often the only person that somebody sees regularly, continuously, week in, week out, if they're being cared for in a community setting. You won't see your general practitioner every day for 6 weeks, but you might see your primary care nurse if in a community setting. So we're the conduits of an awful lot of the information about patients. We're patient advocates. We're often the ones that notice when there's something wrong. Okay? We're the ones that communicate information. And so nurses have this sort of coordinating of care, information passing, supporting patients emotionally, physically, supporting their families emotionally and physically. And a lot of that is not very obvious. The other thing is, and I think that it is important to recognise, it's a gendered workforce. The majority of nurses are female. And that, I think, has implications for my next point, which is, despite the fact they're the largest workforce, and actually the main users of most of the digital technologies that you guys will be involved in developing in healthcare systems, they are very often either not at the table or actually actively, just not involved in the design, procurement, development, and implementation of a lot of digital systems. I'm not going to say that's across the board, because I know I've spoken to people here at this conference who really recognise the importance of getting clinicians in the room, and I've been really reassured by the number of you who've told me that you actually do talk to nurses, but that is not the case in the broader health IT landscape. And I just wanted to highlight to you, I've been involved in a review looking at artificial intelligence systems designed really with nurses in mind. So these are systems that have been designed with nurses being the end users. And what we found 140 studies that reported the development of an AI-based tool. Nearly 50% of them did not have a nurse at all in the team, in any way, shape or form. And yet you're expecting nurses to use that at the other end. There's implications for that. And I also there's numerous examples. I just pulled out a couple from a couple of blogs. If you don't involve nurses and you give them technology to use, they just may not use it. So your EHR implementation completely fails, or they'll use it in other ways. And I'm going to talk about that a little bit later in my talk. I think it's also worth mentioning that we are, I think, in healthcare at a tipping point in terms of nurses' engagement with the use of digital technologies. And I think that there's an opportunity now to change the way that we do things due to COVID. I have a group of clinicians that I work with now who suddenly, the acceleration of the use of digital technology to support clinical care has just been exponential, as you all know. And actually, we're now playing catch up, I think, in a lot of the health IT world with the realities of actually having to use systems that possibly weren't designed and not fit for purpose because we had to implement so quickly. So why is it important that you involve nurses in the design, procurement, implementation of electronic health records and other digital technologies? We know that usability is a really important issue when designing technology. I'm hoping that most of you have seen this. This is Nielsen's criteria for a system acceptability. So it's the sorts of criteria we should be looking at to make sure that anything we give a clinician to use, including a nurse, actually is fit for purpose. It needs to be easy to learn, efficient to use, easy to remember, needs to be able to be used with few errors, and it should be pleasing to use. You shouldn't have people swearing at the computer screen because they can't find the information, which does happen, and I'm sure you know that. And what we want is systems that fulfill all these criteria so that it makes it easier for nurses and other clinicians to do their work. However, that's not necessarily the case. So I wanted to give you an example just to illustrate to you what happens when we don't take usability in mind when we're designing systems. One of the studies that I was involved with a very long while ago, I was lucky enough to take a fellowship year out in the United States. I worked somewhere which had just implemented an integrated system-wide electronic health record, and the aim was that that would make the whole healthcare system paperless. Had nursing documentation, barcode medication administration. It was one of the first systems in the US to do this. I did some work looking at what the impact of that was on nurses. And I went out into the wards and units to observe the nurses using the system. And the one thing that struck me straight away was the preponderance of paper. This was meant to be a paper-based system. It's a very powerful electronic health record, had every single piece of information and data you would ever want about all of the patients you were caring for as a nurse. Every single nurse had a piece of paper, just like this one, in their pockets. Every single one. And, but they could get that information off the EHR, and they could find it at the tap of a button. So why were they doing that? It's because the system is not designed to fit with the way that nurses work, okay? If you look closely at this paper, it's actually information about 2 patients. We have ones, if you're looking after 6 patients, you'd have a bit of paper with 6 patients on. And they write down all the bits of information that they need to know to be able to care for those patients over the shift. Things like timing of medication, whether or not they're diabetic and I need to do an insulin measure, if they're going for a test or not. And the reason for that is that nurses have to prioritise a lot. So if you have 4 patients who all have drugs due at the same time, you can't give all 4 patients the same drug at the same time. It's physically impossible. So you have to prioritise who needs what drug the most. The only way I can do that is if I have all the information about all the patients I'm looking after and their drug times on one sheet of paper to figure it out. And the EHR system was not designed to do that. It was looking at one patient at a time, linear. Okay, so it's a very simple example. The other thing that I noticed, which was a real concern, and again I'll come back to, is they were writing down people's blood glucose measures on this bit of paper, which from a patient safety point of view, if you've got 3 people who are diabetic and you've got blood glucose measures for all 3 of them, you could theoretically get that a bit muddled if you were going to put it into a chart later on. The reason they did that is because they needed those glucose measures to give a patient insulin just before lunch, and the system, they put the blood glucose measure in one part of the system and it didn't communicate with the med chart. So the only way that they could find that information without clicking through 20 screens to go back to find the data was to write it on a bit of paper. So that's what I mean about usability being important to support people's care. Moving on a little bit, I just wanted to show you this. I've recently finished a study looking at nurses' experiences of using technology during the pandemic. And one of the things that we asked them to do in the survey was rate the usability of the systems that they were using a system usability scale, which is the standard measure of usability for most digital systems. I just wanted to highlight to you, so the dotted line is 70, which is the industry standard for a usable system. Sorry, it's not the prettiest graph, but down the side is the different types of technology that have been introduced. Unsurprisingly, an awful lot of the technology systems introduced during the pandemic were to do with things like appointments and patient monitoring, data sharing. What we found was, apart from e-prescribing, none of the systems had good usability, and the variation was incredible. So the dots are the mean and the lines are the standard deviations and the variation. So we have a long way to go. What we want is for all those systems to have a graph like the e-prescribing, and they're not. And there's issues to do with why we're implementing systems that do these sorts of things that are not usable for the nurses using them. So, interoperability is also a really important issue. And I come from the UK, where I think I would be, it's variable, the amount of digital maturity we have in our healthcare organisations. And we have a continuum from some healthcare trusts, some healthcare hospitals that are predominantly still on paper, all the way through to my local NHS trust, which is a digitally mature system with an integrated electronic health record. So what do you do when you're working in an environment where your predominant role is to coordinate care and communicate with people, but the systems that you have available to you do not talk to each other? And it is a real issue and a real concern. And I just wanted to give you a real life example of this. I was at a conference about 3 weeks ago, one of our local hospitals. They have a big integrated electronic health record system, and they'd brought in nurses from across the community to talk about improving digital nursing. And one of the nurses put her hand up. She works in the hospital, she's a children's nurse, cares for children with very complex care needs. So those children are under the care of the hospital, but actually most of the time they're looked after in the community, either at a special school or by their primary care practitioner. And she said, how can you help me? Because I obviously need to have information from these different groups of people, the school nurse, for the school where these children are being cared for, and from their primary care practitioners, so that I can integrate and communicate, coordinate their care. And the primary care practitioner electronic health record doesn't talk to our electronic health record. So every time I need information from the GP, he has to print it off and send it to me, scan it and send it to me. And the school nurse doesn't have an electronic health system at all, so it's all on paper notes. So I don't know what she's doing at all, because I can't get any information out of her unless I manage to get her on the telephone. So we have a long way to go in terms of ensuring that the systems we give people to use enable them to do the care that they need to. And I just wanted to give you a reality check. That's where a lot of nurses are working, in systems where they are combining paper and electronic health, and it's really, really hard to get the information they need. The idea is that if we take paper and put it into a computer system, then it will make life a lot easier for people. And actually, one of the biggest issues about not involving nurses and other clinicians in the design of the systems we get them to use is that actually you end up making their lives even worse. And there's a whole load of work coming out of the US now, which is slightly more digitally mature than where I work in the UK, suggesting that actually what's happened is with the implementation of these digital technology systems, electronic health records, is that it's leading to burnout. Why is that important for nurses? I think I heard somebody earlier on saying we have a nursing shortage globally. We actually do. The UK is no different. Every country I'm speaking to, there's a shortage of nurses. And there is research to show that poor usability of digital systems and the impact of that on their stress and burnout means that they're leaving the profession. We cannot afford to get this wrong anymore, because we don't have enough nurses to go around anyway. And if what we're doing is actually encouraging them to leave because what we're giving them is not fit for purpose, we have a problem. So it is actually really important. The other thing about not actually having good systems, good standards, poor interoperability, is the threats to patient safety. So the example that I gave you earlier with the nurse writing down the glucose measure on a bit of paper so that she could give an insulin dose, or they could give an insulin dose a bit later on, that has really big implications for patient safety. If you have 3 patients who have diabetes, you have 3 glucose measures, you're busy, you look at the wrong glucose measure and give somebody the wrong dose of insulin because it's not in the right drug chart, it's written down on a bit of paper, you could actually end up killing somebody. There is actually real threats to patient safety if we don't have good interoperability, communication of information across systems, and ways of doing things differently. And also, I just wanted to put a shout out for patients as well. How many times have you been to a healthcare practitioner's office and been asked to give them the same information over and over and over again? The clinicians get frustrated because they have to ask the same information over again. Patients get frustrated because they have to give the same information over again. In an ideal world, we should be able to give that information once and we should never have to give it again unless it's changed. So I think what you guys are doing in terms of developing the standards and the approaches to enable that as a vision is really, really important. So my last slide about why this is important is actually to do with the way that nurses work. Nurses are problem solvers. I can guarantee if you give them a digital system to use and it isn't fit for purpose, they will do something which Ring calls hacking it. Yeah, I call it a workaround, but basically they will hack your system to get it to work effectively. I can guarantee the way they will do that, you will not be able to predict, because they do it in such amazing ways. I mean, seriously, some of the things I have seen nurses do to get a system to work are amazing. I'll give you another example. One of the studies that I was involved with was looking at computerized decision support systems across the UK. It was a while ago, so the systems weren't integrated into anything else, so they were standalone systems. And one of the sites we went to, the nurses had been given a triage system to use. It was a walk-in centre. So patients would come in with a condition and the nurse would triage them and see if they needed to go to hospital or treat them. And some bright spark had decided that the best thing to do to help nurses do that would be to give them decision support tool, which we actually then used for our online triaging patient telephone service. So the software they were using had been designed for telephone triage, not face-to-face triage. That means some of the questions that they were being asked to use for that system were completely nonsensical, because you can see the person in front of you. You don't have to ask them if they are conscious. Yeah, I'm not joking. So what the nurses did was they were like, well, this is completely useless to help support my decision making. I see somebody come in through the door. I know what's wrong with them. So I basically fill out the protocol after they've left to make sure that it comes up with the right answer. Yeah, that's exactly what they did. They said, well, I knew that that person needed to go to hospital. So I knew if I put in yes, 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 and yes, it would tell me to send them to hospital. So I just did it after they left. Yeah. So, so it's really good that they get these systems to work really well, but actually it can cause some real issues to do with patient safety. One of the biggest areas of work that I've been involved with has been looking at workarounds to do with medication administration. If you don't have a good, well-designed medication administration system, particularly in hospitals, and nurses produce workarounds, you end up with errors that can cause big problems. One of the other things I've seen is like the scanner didn't work for the barcodes. So, and you know, this doesn't work when it's on the patient's wrist. So we basically just tape all of the barcodes for each patient onto the drug cart and scan that instead. Yeah. That could be a problem if you scan the wrong patient. So, you know, there's all sorts of issues. So, what can we do about it? The first thing, my first message to you, is ask nurses. Find out what the problems are that they need solving. They will tell you. They're pretty good at being vocal if you get them in the room in the right way. Don't assume that doctors know what the nurses do, because quite often they don't. And also, make sure that you don't have just one nurse in the room, because they won't say anything. I mean, remember what I said, it's a gendered profession. There's quite a lot of hierarchy in hospitals. If you're trying to design a system and you get a bunch of clinicians together and the nurses are outnumbered by my esteemed medical colleagues, they won't say very much. They'll let the doctors do the talking. And that's not because they haven't got anything to say, it's because you haven't given them the opportunity to say it in a safe space. And apologies to the doctors in the room. I have met a couple and you are lovely and I'm sure you wouldn't do that, but it is an issue. And what happens when you do ask the nurses and you co-design systems with them is that you end up with very simple solutions to actually what are, for them, very, very meaty problems. So I worked for a while out in the United States and I had a joint appointment with the Visiting Nurse Service of New York and Columbia University. So I was working with community nurses and they had an electronic health record system, and we had an issue in the organisation about patients with heart failure going back into hospital immediately after being discharged. So we wanted to do some work to see is there ways in which we could intervene using the digital technology to help the nurses identify patients for whom they needed to be more concerned about and put interventions in earlier. So we did some co-design, we did some work with them asking them what the key issue was. And one of the biggest issues was that a sign that a patient's deteriorating with heart failure is their weight is going up and that their other vital signs start changing. But the nurses couldn't tell that from the chart because they may get a patient's weight every time they go and visit, but it was in each visit record. And in order to see if there was a change, they had to click back to every previous record to see if that was what the weight was last time they went in, and then what the weight was the time before. And then they had to write it all down on a bit of paper, and if they were really good, they might graph it on a bit of paper. It took them 10, 15 minutes to do that. And I said, you know, it'd be really good if we could just see that when we open up a patient's chart. So we designed a system so they could see it when they opened up the patient's chart. And that's what this is on the right-hand side. And we did a lot of work asking them what measures they wanted to see. They can customize it, so they could look at it as a bar graph or as a line graph, depending on how they interpreted information more easily. And they actually wanted it color-coded as well. They wanted to be able to set the parameters and see. It got to the testing feasibility stage, and it was tested, and we did heuristic evaluation, and everybody loved it. And then the EHR system changed, and I had to not implement it into practice. It's one of my saddest moments, because that was a really, the nurses that we tested it with found it a really useful tool. But it's very simple. I mean, my visualization colleagues were like, well, you know, that's like the most simple visualization you could probably ever come up with. Could we not do something more exciting? It's like, that's what they want. They want simple, want to be able to see it. The next thing is that we do understand, I mean, I understand, and I think a lot of my colleagues understand, that standards and data, you know, standards and data are really important. And trust me, if you don't get the usability right, and you don't get the systems right, so the nurses can enter the data you need them to enter in the way you want them to, none of the other stuff that you guys want to do will work, right? You know that electronic health record data is not as good as it could be. And nurses will work around any system and corrupt any data plan you want if it doesn't work for them. So actually enabling good quality data to be collected probably means that we need to be engaging much more from my community with you guys. We have nursing terminologies, we have nursing data sets. They need to be built into, and some of my colleagues in the States, as I said, this is not my world, but I do work with people who've done this, have mapped it to SNOMED and LOINC. We have ways of being able to map nurses' work and being able to record what nurses do so that there's a benefit for them filling out your data sets. If we can codify the way that nurses work and what nurses do, and feed it back to them to help them support their practice. The back end of that is that you get highly structured, well-curated data. Okay? So we need to be working together a bit more to integrate the nursing systems in there. And I just wanted to highlight to you that they exist. If you didn't know, we do have, nurses being nurses, we have more than one terminology, obviously, but we do have them. And my final message is that I work in a community where there is a lot of goodwill. There's a recognition that using digital technology definitely has the potential to support our practice, but we just don't know where to go in order to help us get there. And this is a quote from that study I was talking about, where I was looking at digital technology during the pandemic. And one of the people that we interviewed basically said, at the moment, there's a big divide between the people who develop the digital solutions and those of us who are doing patient care. And if we can cross that divide, if we can start talking to each other more effectively, we can probably end up in a situation where we have systems that support nursing care, systems that support patients, and also enable interoperability and enable efficiency in care. But we need to be supported along the way. And we need to be able to come up with better ways and better systems for involving nurses and other clinicians and patients, anyone who has any buy-in in these systems, in the room at the start. My message, my final message to you is please, please, don't develop something and then just give it to a nurse to use. It will fail, and they will subvert it in some way. So, you know, just involve them to start off with. And I think that's my end of things. Thank you.
Thank you, Dawn. We have time for a few questions, and one came in from our online audience. And the question is asked by Elise, and her question is, what about digital solutions meant for providers, nurses, and administrators? Is it sufficient to have different views for different users? Or is it useful for nurses to see the other views, to see what a provider sees, for example?
It depends. And I think that that's one of the reasons about actually really understanding what it is you're trying to get the system to do and what people need to see in order to be able to do their work. So I could see in some situations it might be very useful for nurses to be able to see what other people see, but in other situations it may not be. And I think it's recognising that we probably need to be more flexible, and it could also be individualised. So for some practitioners, they may want to see one view, and other practitioners may want to see something else. And I think that that's one of the exciting things about some of the things that you guys are doing with FIRE, is that that flexibility suddenly exists in a way it doesn't in some of our more traditional systems. Some of the work that we did with the nurses when I was developing the dashboard, we looked at how people understood different types of graphical information. And actually some people understand bar graphs, some people understand line graphs. So why do we give them one and not the other? Let them choose. And I think that might be, it's not, so I think probably yes, but it depends.
Thank you for amazing presentation. I saw few examples where very enthusiastic teams of IT workers and practitioners created really amazing applications. But the problem is that it may be quite expensive, and how we can extrapolate this experience to the country level. And the question is, what do you think, how variable is the processes we're trying to automate? And is there some maybe knowledge base of best practices? For example, if I want to create medical administration module or application, I can go to some place and see actually best practices that were used in the world. Yeah, thanks.
So I have the ideal world solution which is yes, it would be great if we could do that. And I think in the UK, which is where I am now based, we have a community of practice that are starting to do that. With regards to your first question about variability, we work in a system where everybody thinks what they do locally is the best, and even with the best will in the world introducing clinical guidelines and standards, we still see variability across healthcare. That one of the pictures that I showed of the paper was a colleague of mine who works in a trust down in the southeast of England, and they're implementing an EHR, and they did a nursing record party. So everybody brought along all of the paper records that they use for nursing and sort of ditched them ceremoniously. They had 20 different ways of measuring somebody's pain in one trust. So that's within an organisation. We don't have standardisation quite often in our organisations in healthcare, certainly where I work. So if we don't have standardisation in processes in an organisation, how can we standardise them across organisations? So I think that there is, there's always a balance, isn't there, between standardisation and flexibility to recognise context. And I think we've got a way to go to get there. But I do think that there's a recognition, certainly in the UK, that we need to be sharing best practice more, and that's beginning to happen. Does that answer your question?
Virginia.
Hi, Dawn. Thank you
Hiya.
so much. I want your help with something, because I talk about it, but you would do a better job defining this. So I work with a lot of nurses that are no longer full-time practicing nursing. They are instead helping to configure EHRs or running committees and talking about and designing systems. And some of them get a specialized kind of training called nursing informatics. And I wondered if you could kind of define what nursing informatics is and what it means to be a nurse informatician.
Okay, do you want the US version or the UK version? Because they're different.
I'd like both.
So in the US, I think that you have a much stronger career structure for people who are for nurses who are involved in informatics, and much more at the front end of designing systems, writing standards, normally would have a master's degree in nursing informatics, would really understand the underpinning science behind it, may go off and be a chief nursing informatics officer and be involved in implementing systems in their organisations. But there's a real defined career structure. In the UK, it's slightly different. We are way behind, so we don't have any masters in nursing informatics. We've only got some. We've very recently started to offer health clinical informatics masters. Most of the chief nursing informatics officers I work with regularly have no formal training in informatics. They've just fallen into it because they're the digital, they're the techie nurse. They're the one that isn't frightened of computers, so they end up being given that job to do. And that's a challenge, I think. But I think it's this whole enabling the use and adoption of efficient and effective information systems to support nursing care and helping that. Does that answer your question?
Yeah, and just to point out that there are nurses that they're what does someone say? They're the computer nurses.
Yeah,
Yeah.
yeah. But they shouldn't be. Yeah.
All right, thank you.
Thank you very much.
Well, then it's up to Grahame. I know you don't mind that I let it slip a few minutes. Are you wired? I'm all right. Yeah, okay.
Hello everyone. It's sensational to be back at DevDays. Some of you will remember that I missed my very first DevDays last year because I had COVID. So I'm really happy to be back, and I've really enjoyed DevDays like I always do. Thank you to each and all of you for making it enjoyable. I was talking to Dan last night about this, and this DevDays, this is how I feel about it too, and Dan commented, is that if you look at the sessions, the session scopes, the topics reflect a gradual broadening of our focus. If you go back to where we were, it was very dev focused, very programming. Can we even do this thing? And then over time, we've spread out national programs, clinical solutions, informatics. It's a wonderful thing for me to see, and for us to see that spread as we become mature. And so I thank you for all that too. And of course, I'm going to comment on this, but community, right? This is what we're about. I present about fire all around the world, and I say early on in most of my presentations that fire is two things. It's a technical specification and a community, but the community is the important part. It's the part that builds the technical specification, that builds the energy, that builds the motivation. So thank you for all being part of it. I was talking to some of my team, some of the community today about this, and what we really value is feedback. I've had a couple of people mention, I wasn't really sure I should, bother the community with something. No, we want to hear. Even if you think it's trivial, we know something's happening. We know what's going on, and so that's really great. And we're going to go out to feedback later this year formally and ask people, how are you using fire? What are your plans for fire as part of our decisions around where we want to take the future release 6. And too much what we get is, oh, this bit doesn't work or that bit doesn't work. Everyone's happy to tell us those things, right? But we want to hear, this bit works, we're using this bit, we're doing this. And even if you just ask us, hey, I'm not really sure about this, I mean, usually if you're not sure about it, it probably means we could be clearer. And so don't hesitate to give us feedback, good and bad, and tell us how things are going. I actually have, here's something for you to all think about. I have a map that the HL7 webmaster sent me of the geographical locations of all the Jira users who have created issues or logged into Jira in the last month. I was a little bit surprised by that map and how selective it is. So I encourage you all to engage. I can't get the same map for Julep, that's what I really wanted, but they do privacy, so I can't get that one. But I can get the one for Jira, and so sooner or later I will start sharing that. But it's a bit European and American centric. So I hope that we can spread that one out. This DevDays, we've had Women on Fire. So first of all, I want to say a few things about this. I am firmly in favour of women being involved in fire. That's not much of a surprise. I'm in favour of everybody being involved, right? And it's not like, I mean, I've been doing health informatics in one form or another for 25-something years, and I'm pretty sure that there is no functional ability or relevant difference between men and women in their ability to do health informatics. It's pretty straightforward, right? It's got nothing to do with gender. And so we're all here, we're all good, that's good. But I've also learned that it's just not quite the same. And a lot of it, and listening to women, and I went to the Women at Lunch, Women on Fire lunch a little bit today, what I've learned is a lot of it is about the initial engagement. Now, we engage, we are the first timers at a conference, and then they give us a badge. It's the first timers at some conferences, and you're like, I got a first timer badge. Now I feel embarrassed about having a first timer badge. Or we don't give people a first timer badge like this conference, and everyone says, it's really good to know who's a first timer. Sometimes you just can't win. But then you come here for your first time, you don't know anybody, you don't know the norms, you don't know the practices, the culture. Now, some people are just like, oh, whatever, I don't care. I'm me, I'm fine. But that's actually not the majority of people, and it's particularly not as likely that women will feel that way. They're more likely to be sensitive and nervous and concerned about how things are going to work. And so it's for all of us to see people who we don't know or that are not engaged with friends and reach out and welcome them. You are welcome. This is a volunteer community. There's nobody who's not welcome. So reach out and make people welcome. I've tried to do that as much as I can this meeting. Say hello to everybody. It's great to see you. Tell me about yourself. It's not hard. But it's, as we get bigger and bigger and bigger as a community, which is sensational, it's really good for everybody to be welcoming. But hey, I was hearing that message and thinking about that message, and Dawn said to me, and then she said to all of you, this is a really welcoming community. So I am not saying we're not good at this. I'm happy to report that the feedback that I got from the women on Fire Lunch was, we're good at this. So great, we're good at this, we can be gooder at this in the future. Mentoring and welcoming are a very important part of what we do. And I think there's a little bit of a challenge here for us there, and I emphasise that not just because of the Women on Fire initiative, thanks Rian for working on that, but because I feel as though we're at an inflection point as a community. We are, as a standards process, I talked this morning about how we are changing our process and our culture and our norms in order to push the standard harder towards stability. So, because that's the very, very strong market feedback that we're getting, and that brings challenges to any organisation to adjust to external reality and change our norms and our culture and our ways of behaving. But also, as I look at the challenges that we face around the world in healthcare, Dawn gave a very good summary of the institutional side challenges, and we can take a much broader look at the healthcare system as a whole. And I see now a real swell across the world to say, we recognise that we have really significant problems, and the only tool that we have to solve the problems that we have, and at the end of the day, the problem, we only have one problem. Everything else funnels into the one problem. We don't have enough workforce. Pretty much that's what it comes down to. There's health stresses and there's trends and so forth, but they all end up being, we just don't have enough staff to do workforce to do healthcare. And the only idea I've ever heard anywhere in the world about that, given that it's pretty much a worldwide market for the workforce now, is digital health will make them more efficient. Has it done so? Not very much. We need to do better. The governments are waking up. We need to do better. And so I feel as though we're at an inflection point now where that's going to become increasingly our focus. Post-COVID, there's sort of a shock that's starting to really work through policymakers. And so all of us need to be agile and reactive to external stimuli. You will see that politicians are not very good at this. Doctors and nurses are not good at this. Lawyers are particularly not good at this. But we can be good at this. But everything that we do, every change that you make, every new thing that you introduce that's a brilliant idea is potentially a safety problem. Dawn spoke well about that. Thank you, Dawn. And one thing that I've learned over 25 years of doing this is that every information silo, which is what we design and always have designed, every information silo has what Professor Enrico Coria in Australia calls the real system. There's the software system, there's the official system that the way it's supposed to work, and then there's the actual way that it works. And Enrico and I invented a measure which used to be better than it is now, which is you could measure how good the system was at matching its expectations by counting post-it notes on monitors and notice boards. Right? And the more post-it notes there was on the computer, then the more there was informal knowledge about how the system worked. That's kind of collapsed now with bring your own device, and no one puts sticky notes on their phone, and so we've actually gone backwards in terms of the informal knowledge. So every system I've ever worked with has informal knowledge, and if any of you who are involved in the HL7 side of the standards process, you all know this. We got lots of informal knowledge going on. It's everywhere. It's part of our norms. But when you take two different information systems with two different sets of informal knowledge and hook them up, the informal knowledge will run into each other disastrously. So it should be an expectation for all of your projects that anytime you do any interoperability, you should anticipate automatically that there will be safety consequences. not based on the documentation, based on all the non-documented things. You should have a process for this, a follow-up process, expect problems, find them early, expect to be able to be having to respond to them, and to pick up on Dawn's point, don't just involve nurses early in the process, go out and find out what they're actually doing so that you know what to adapt to, because users adapt to your software, and so your software will have to adapt to your users. It's true wherever I've been, and for me that's the real safety issue at work. Because what I've learned, and you've all heard me say this, or most of you have heard me say this before, that what I've learned is that institutions keep records for institutional purposes. They don't keep it for the sake of their staff who are providing the healthcare, nor do they keep it for the sake of the patients receiving the healthcare. That's really what I want to change, so that we keep records for the benefit of the individuals involved, the recipients of care, their families, and the providers of care, be they doctors, nurses, administrators, cleaners, whatever. They're all providing care one way or another. Now, I want to thank you all again for coming. For me, fire has been a personal journey that I started. Yes, COVID was a personal journey too. 3 times. Thank you very much, COVID. Fire was a personal journey that I started 12 years ago now. In the beginning, a few weeks after I started it, Lloyd and Ewout jumped on board. We were talking this week about the meeting that Lloyd, Ewout and I had under the stairs in San Antonio on a Sunday morning, planning how to convince any committee in HL7 to pay even the slightest attention to fire. We didn't even call it fire back then. But we knew that it was a good idea and it could become something important. We just needed people to engage. And we were talking about how dramatic a change that was over the time for HL7 as we gradually took over HL7. But for me, and I think for the other early participants, it was a labour of love. And often, I'm sure many of you have seen the XKCD cartoon where there's like 15 standards and someone says, let's write a better standard, and then there's 16. We were very aware of that risk, and was it really a good idea to do fire? And maybe it wasn't. And it was a really, at times, very lonely process with people at HL7, getting into me for doing it and not supporting us. And so those early support is very valuable. But for me, all along, the bottom line is I have done fire, devoted much of my life, adult life, to doing it because I believe that each of us has to contribute to society beyond just having a job and earning some money. And so I encourage all of you, if you value civil society, living in a civil society with rule of law to the degree that you do and can, if you value that, then it's on each of us to spend a little bit of our time each day or each week contributing to civil society. You can do it, as many of you here do, by contributing to fire or some other professional civil society. Health, one's great, and there's plenty of offshoots of the fire community exploring how to apply fire best in some particular context, and that public treasure that we build of public knowledge is a part of contributing to civil society. But I encourage all of you to spend some of your time contributing to civil society somehow. And now I want to recognise a company that has done so. So organisers, come on up the front, please. Now, obviously, running DevDays is a commercial operation. But honestly, if I was Rian and running Filey, I don't think I'd run this thing. So Rian, thank you very much for running this thing. Now you need a microphone, right? Have we got a microphone here, or do you want?
I have one.
Yeah, just hold this.
Oh no, you keep that.
Okay.
There's a mic here.
Anyway, thank you, everyone.
Thank you very much, Grahame. Thanks for this wonderful talk. So first of all, can I have more yellow shirts here from the Firely team? Just the Firely team. Yes, there's a few more. Thanks very much. Now you know that there's white collar folks and blue collar folks. And who are the more important? The blue collars. So can I have those two blue collars over here as well? And so the challenge with DevDays is since COVID, we were online, and then last year we did the hybrid for the first time. And hybrid it's two channels. It's on-site and it's online. But the complexity is much more than just twice. It's just you have to record, you have to stream. The complexity is beyond belief. And so we have 2 AV people, we have 2 moderators for each session. We have 150 sessions, presentations. It's awful. But thanks to these wonderful people, we've managed another edition. So thank you very much. And team, thanks so much for doing this. Can I have a round of applause, please, for these people? Thank you. And now what I would like to do is ask the Firely people to get off stage and the Vermonster people to stay on stage, please. Blue collars can leave as well. HL7, thank you. Can I have the Vermonster people here? Because you might think, wow, what a large company, so many yellow shirts, but actually we were 2. We have our partner in the US, Vermonster, out of Boston, who, by the way, are we've been working with for many years now because they are the most excellent fire experts in the field, helping out with customer projects in the US, for our customers in the US. We reached out to them, hey, we have so many sessions, can you help out with the moderation, basically. So these are the wonderful folks from Vermonster, flew over from Boston to help out with the DevDays 2023. And I have a present for you, for each one of you. I'm going to pick out one of you, but we have these presents in the back. Vicky, I've somehow chosen you as the example. Because, you know, when you have a business relationship and it evolves into a friendship over the years, that is really, really special. Vicky, I'm going to hand over a small present, a token of appreciation. We have one for each one of you. Vermonster, thank you very much for helping. Oh, yeah. Yeah. And then there is someone who is just whispering something in my ear. Vermonster, please, you can go back. Because I want to have the stage for one person in particular, who is Marita. Marita, can you step over, please? Because, Marita, someone told me that this is your 10th edition of DevDays. Yeah, and you know, I had forgotten about it. I'm embarrassed to say this is your 10th edition. I only count the entire number of editions. We could never have done DevDays without you, without your help. It's gotten out of hand completely. When we first did DevDays, it was just in our office, and I know some of you who were there, they know we just moved the desks aside, and we had DevDays that first few sessions. Then it got out of hand. We asked you, please help. We cannot do this. This is your 10th edition. Rita, thank you so much for doing this, and I have a small present for you. Thank you very much. And then finally, can I have Marianne here with me? Marianne, are you here? So, as you know, DevDays is a collaboration between HL7 and Firely. And what you don't know is that we have online moderators in the US helping out with the online moderation. They're a team, an HL7 team, who are doing the online moderation. And maybe, Marianne, I want to thank HL7 for making this happen, but maybe you would like to thank the online moderators in your team.
Sure. I hope they're watching. I don't know. But yes, thank you. There's 8 people back home that were helping moderate also. So they were in the virtual sessions helping out. And they had to wake up very early so that they could help out. So that was awesome.
Thank you. Thank you, Marianne. Thank you. And now, before we go over to the farewell drinks, I would like to ask Ewout, please come on stage. I think Ewout is the closest a human being can get to being in multiple places at the same time. He's online, he's offline, and he's in every room. We call him Mr. DevDays. And I asked Ewout 2 years ago, Ewout, can you help out with DevDays? And he said, yes, certainly, but you have to do it as a side job. Okay, I can do that. So he did. And therefore, Ewout, I would like to ask you, and you don't know about this, but we have one slide announcing DevDays 2024. Would you like to take the honor, please?
I'd be honored. Thank you.
Can we have that slide?
And a drum roll. Oh, too late. Good. So, next year we're back in the US, the week of June 10th, and we're going to beautiful Minneapolis, Minnesota. Yeah? Almost certain. Did we already sign the contract? No.
Did not sign the contract.
Almost.
Okay, so, no, go ahead.
No, but you actually been to Minnesota, so.
Yeah. No, but please take note of this. The week of June 10th, more details, Minneapolis, Minnesota. And with this, that's the end of DevDays 2023. See you at Farewell Drinks. Thanks very much.